so. Okay, I'm gonna wait like another minute and then we'll get going. Hello, everybody. Welcome back from your break. My name is Emily Zalkowski. I'm the Director for Program Management in the Managed Care area in Texas Medicaid. And I am here to introduce Dr. Betsy Shenkman. Dr. Betsy Shenkman is the Chair of Health Outcomes and Policy and Director of the Institute for Child Health Policy at the University of Florida. In addition, she is a health outcomes researcher working to achieve two goals: determine which combinations of healthcare delivery, community, and patient factors influence quality and outcomes of care. And the second goal is the development of corresponding evidence-based healthcare delivery system and patient-centric interventions to improve outcomes of care. Dr. Shenkman leads two major state Medicaid and Children's Health Insurance Program evaluations, the Texas Medicaid Evaluation Project, and the Florida Kid Care and Healthy Kids evaluations. The Institute for Child Health Policy at the University of Florida is our external quality review organization for Texas Medicaid. Dr. Shenkman's research has been funded by the Agency for Healthcare Research and Quality, the Robert Wood Johnson Foundation, the Centers for Medicare and Medicaid Services, the Texas Health and Human Services Commission, and the Florida Agency for Healthcare Administration. Her work is published in journals such as Pediatrics, Health Services Research, Clinical Epidemiology, Pediatric Blood and Cancer, and the American Journal of Public Health. Dr. Shenkman is an elected member of the Society for Pediatric Research and the American Pediatric Society. So please welcome Dr. Shenkman as our lunch keynote speaker.
Emily, thank you very much. It's always a pleasure and a privilege to be here and to be able to talk to you about the quality of care in Texas. So I was asked to talk a little bit about what options we have and what opportunities we have to begin to look at data within the regional healthcare planning areas that you have defined as part of the DSRIP program. And I'm not going to spend much time. The first couple slides are really just a history of DSRIP, and you all have lived that history, so I won't spend much time on it. But this really just goes over the regional healthcare partnerships that are basically focused on supporting and improving healthcare delivery. And I'm going to skip to talking a little bit about the Category 3 and Category 4 measures. So as we've worked with the state of Texas in our EQRO role, we really have looked very closely at a variety of quality of care measures focused on areas such as prenatal care, potentially preventable inpatient admissions, emergency department visits, and others. And as we've looked at these, many of them align quite well with the projects that you all have developed, and it's been very exciting to hear about them. Very exciting to hear about the partnerships that you have and how you're really trying to integrate care and reduce potentially preventable events. So we focused very carefully on what were key measures that were defined as part of the DSRIP program and how they best align with what the work we're doing in the External Quality Review Organization. So all of you have identified some key challenges, and you've been talking about that throughout the morning. You've looked at the high chronic disease burden, maternal and child health outcomes are key issues that you've identified, and also many unmet mental and behavioral health needs, along with the importance of really providing care navigation, helping people with those difficult transitions as they move from the hospital back into the community. So what I wanted to focus on over this time that we have together is really looking at what are some statewide rates we're seeing for the Medicaid population in the RHPs, and showing percentiles, how the different RHPs compare from some of the highest performing to some of the ones that have more challenges, and also how it compares, when possible, to some state and national information. We've organized our measures into behavioral health, access to care, and then the potentially preventable events. So let me just talk a little bit about the measures themselves before we go into the results. So for the behavioral health measures, there's a series of them that we calculated that we've provided to Texas. But today I'm only going to focus on the ones that are in red. There were so many that we can present. HHSC does have the information, and I'm sure that they can share that with you. But for today, for behavioral health, we'll talk about antidepressant medication management, and we'll also talk about follow-up after inpatient stays for mental illness, both 7 and 30-day follow-up. For our access to care measures, our focus, again, we've calculated all of these, but for today's presentation, we'll talk about children and adolescent access to primary care providers, and then talk about ongoing prenatal care and its frequency, and then also the postpartum care visits. We've calculated utilization measures, and I'm really not going to talk about these today. They are available. We've given them to HHSC. Utilization in and of itself is neither good nor bad. It really needs to be viewed in some kind of context. So we do have these measures. They can be useful just to look at trends, but I won't talk about them a lot today. Instead, we're really going to focus on potentially preventable events. We've calculated all of these, the admissions, the complications, the readmissions, but for today's presentation, we're going to talk about potentially preventable admissions, potentially preventable ED visits, and then several of you have talked about asthma and diabetes care, so we'll be talking about the Agency for Healthcare Research and Quality, pediatric quality indicator for asthma admission rates, and then also the diabetes short-term complication admission rate for children. So one of the things that you'll be talking about, and you talked about this morning, but you'll also be talking about this afternoon in some of the breakout sessions, really is around data. So let me talk for a minute about the data that we used, and then at the end of the presentation, hopefully we can have some discussion and revisit what kinds of data are available and how can we best use it to help inform what's going on in the RHPs. So the data I'm presenting today are from Medicaid, for the Medicaid Managed Care Program for calendar year 2013. And the data for calendar year 2014 will be available to the Health and Human Services Commission in October, so that there's the opportunity to begin developing trends and looking at information across time. We excluded anybody that was dually eligible for Medicaid and Medicare. However, we do have Medicare data now for the dual eligibles that we can link to the Medicaid data, so hopefully future presentations will include that. We recognize that what we're presenting today is not fully reflective of your population. You know, you're dealing with the Medicaid population, but you're dealing with individuals who are uninsured. So we really want to talk more about what are the opportunities to work with you around all payer data, possibly some electronic health record data, and then including and bringing that together with the Medicaid data that we have. But the information today we hope is helpful to you in that it provides, I think, background information about what's going on in the RHPs. So why don't we go ahead with behavioral health, and let's start with our antidepressant medication management measure. And the reason why we like to talk about this one to start is because this is really a very important measure for so many things. At the end of the last session, Dr. Becker asked about, well, what about postpartum depression? There was one of the presenters was talking about registry data at Parkland and gave an example of an individual that was getting more intense care management. You know, depression really has a huge effect on how well people can take care of themselves and on their cognitive functioning and their ability to self-manage. So this is an extremely important measure. So we calculate all of our measures that are labeled HEDIS, and that's the Healthcare Effectiveness Data and Information Set that is nationally accepted. We calculate all of these using software that's certified by the National Committee for Quality Assurance, and all the measures our results are reviewed by an external auditor so that there's a lot of confidence in what we calculate. So the depression measure, as do all of them, have very specific technical definitions, and that's really important when you want to measure outcomes, and hopefully you'll talk about this afternoon in your breakout sessions, really how do you standardize some of these measures. So for this, we're looking at individuals who are 18 or older with a diagnosis of major depression. They were dispensed a new medication over the 12-week period. There may be a washout period that's included, and then had no antidepressant medications filled in the preceding 105 days. So here is how the different RHPs are looking on this acute phase of antidepressant medication management. So in this instance, the higher the number, the better. So if you look at RHP 13 as an example, 66.2% of individuals in Medicaid in RHP 13 were compliant or were in compliance with getting their medication during this acute phase. Now, if you look at the map, and we've mapped this out, in this instance, the darker colors are better. The darker colors indicate a higher percentage of individuals in compliance with the measure. And the lighter colors are less of a good performance. So you can see there's a big range. Your statewide rate, by the way, is 44%, but there's a big range from 66% in RHP 13 down to 31% in RHP 20. So big range in performance. One of the things that you also can do is compare this to national standards or national benchmarks. And so one of the advantages of looking at this HEDIS measure is we can compare it to how are other Medicaid managed care plans doing nationally. And so in this instance, again, darker colors indicate better performance. And you can see right here that one of the RHPs is actually performing at the 75th percentile or better compared to national data. So not only can we begin to look at, well, what's the backdrop for the RHPs using the Medicaid data, but how do you compare to national performance? And that gives you something to strive for as well. Lighter colors, again, indicate not as good performance. So you can see throughout the state of Texas, for all the RHPs, antidepressant medication management in acute phase is a challenge, and there are definitely areas for improvement. Now, what I'm showing here is just some longitudinal trending of this particular measure. This happens to be for STAR Plus, for the STAR Plus program, which many of you are familiar with. So these are individuals that have disabilities severe enough to qualify for SSI, and these are the ones that are in Medicaid only. And I just show this as an illustration of what we can do to trend longitudinally the performance in the RHPs around these measures, at least for Medicaid, and hopefully for some of the measures that will be upcoming for the all-payer data. So this is showing, as you can see, really relatively no change from 2009 to 2013 in this measure, a slight uptick in 2012, which could be kind of random noise, but very little change in this measure. So this is an area where a lot of work is needed. There's also a follow-up or continuation phase for this measure, and these are individuals who remain on their antidepressant medication for at least 6 months. So you want them to get on the medication appropriately, and then you want them to continue to stay on it. Those are both very important components. So if you look at how they're performing, and again, all of these have the same pattern. You can look and see the continuation phase, and we're not doing quite as well with keeping people on their medication. The best performing area is RHP 13 with 57% of the members remaining in Medicaid, remaining on their antidepressant medication for 6 months, and down to RHP 20, which has 20% of the members. And the maps follow the same pattern to give you a visual impact, again, where darker colors indicate better performance, lighter colors indicate worse performance. So again, opportunities to think about, well, what is it within these RHPs? What are some of the reasons for that, and what are ways to work together? Earlier this morning, Kay Garamani talked about the importance of social determinants of health, and you all have touched on that all through the morning. So these partnerships are really critical. Maybe you can do things to get people on their medication, but then keeping people on their medications really takes, I think, multiple levels of intervention. And this is showing the continuation phase for the depression medication at the national level, and comparing the state of Texas again to Medicaid managed care plans that are reporting across the country. And so you can see again the dark purple areas indicate where areas in Texas that are performing above the 75th percentile or greater. So there are some areas that are very high performing, some areas where, again, there are challenges to keeping people on their medication for depression. This is now showing the trend line for STAR Plus for the continuation phase of the antidepressant medication management, 2010 to 2013. And again, you see kind of a flat, pretty straight line here. So lots of opportunities for improvement. You can see overall as a state, less than 40% of Medicaid managed care enrollees that qualify for this measure are in compliance with it. So much room here for your projects to be thinking about this. So behavioral health, this is another important measure. When patients are hospitalized for an inpatient mental health stay for mental illness, follow-up at 7 days and 30 days can be really critical to helping them remain in the community. And that can help them with their transition and not return to the hospital. So this particular measure is looking at a 7-day follow-up and a 30-day after discharge follow-up. And the individuals for this measure have to be 6 years or older at the time of discharge. And there's a specific list of diagnoses that are required to be present for the inpatient stay before someone can be qualified to be included in the calculation of this measure. So we have the same format here, but now we have a little bit different pattern of performance. And so again, it really varies as to which areas of the state are doing well on different measures. So this is the 7-day follow-up. And now we have RHP 6 with 43% of the members in Medicaid managed care getting follow-up within 7 days after an inpatient stay for a mental illness. And among our lower performing regions, Region 9 at 16.5% of the members. So again, challenges throughout the state. The map very quickly points out where some of the higher performing areas are relative to some of the lower performing areas in the state. Again, darker colors in this instance indicate a stronger performance. And this is the map of how the state as a whole is doing relative to Medicaid managed care nationally. And so if you look at this one, now we don't see any purple. So the purple color indicates performance at the 75th percentile or greater. And in this instance, we don't have any areas in Texas that are performing at that level. So many challenges for getting individuals their follow-up at 7 days after an inpatient stay. This is now showing 30-day, and we see better performance here. More people tend to get follow-up within 30 days, ranging from a high of 66% of individuals to a low of 25% in Region 9. And again, darker colors indicate better performance on the map. And this is showing, again, comparison to national data. This is showing 30-day follow-up compared to the plans nationally. But again, we still don't see the purple area. So we don't see any part of the state where performance is at the 75th percentile or better. So in the behavioral health realm, and I think this is why many of you have focused on this, and many of you really bring this up during your presentations, I think there are a lot more work to do, which would be very, very important as you begin to focus on your projects and expanding them into the next segment. Access to care. The children and adolescent access to primary care practitioners, you can read the definition here, predominantly those that had one or more ambulatory visits to any primary care provider. Texas really has always done well on this measure. So you can see here for all of the RHPs, RHP 5, almost 98% of children saw a primary care provider at least once during the year. The lowest is in 14, and that was at 80%. So overall, the state really does a pretty good job of, in their Medicaid managed care, getting children in to see a physician or a primary care provider at least once during the year. Now we're shifting to frequency of ongoing prenatal care. And there's two ways that, well, there's many ways to measure that, but there's two particular ways from HEDIS that we picked out for this presentation. The first one that I'm going to show you is the rate of individuals receiving at least 81% of their expected prenatal care visits. And you can see the definition, the rest of the definition on this slide. So at least 81% of expected visits. So for Texas, there is quite a bit of variability. The best performing area, 65% of women received 81% of the expected prenatal care visits. And the lowest performing area, 29% of women. And again, if you look at the map, the color coding is the same. Darker colors indicate better performance. The lightest colors indicate the lowest performance. So there's really some real challenges for women with prenatal care and receiving the recommended number of visits. And this is how Texas compares nationally to Medicaid managed care plans reporting. And you can see again that there's one area where there's a little bit of purple down in the bottom, but overall Texas is performing less than the 50th percentile compared to health plans nationally in terms of women getting 81% of their prenatal care visits. Now this is flipping things. This is actually looking at how many women received less than 21% of their expected prenatal visits. So you really want to look at, well, who's at my greatest risk? And these are women that are really getting very, very few of their visits. So now you have to flip your thinking. In this instance, high numbers are not good, low numbers are better. You don't want very many women falling into a category of getting less than 21% of your visits. You prefer none of them do, but you definitely want this to be a low number. And so here, when you look at Texas, one of the regions has as many as 41% of the women in Medicaid managed care getting less than 21% of recommended prenatal care visits, down to one of the regions that only has 7.2% of women getting less than 21% of their visits. So really, in this instance, again, the high numbers are not good. So in this case, the darker colors indicate worse performance and the lighter colors indicate better performance. And it would be great, it would be hard to do, but somehow to overlay all of these and begin thinking about, well, where do we have multiple risk factors for poor performance across several of these measures? So again, a lot of work to be done, I think, on prenatal care. This is showing how the state compares to the plans nationally. And again, you want your lighter colors indicate a better performance. So there are areas in the state, you can see big dark sections where the state is not performing as well as it could relative to national benchmarks. Postpartum care, this is looking at care delivered 3 to 8 weeks after delivery, and there's very specific parameters for what counts as postpartum care. And this is also a very important time for screening, for making sure that there are reviewing how mom is doing, reviewing postpartum depression issues. Postpartum visits, as you know, are really extremely important and linked to very positive outcomes for mom and baby. So again here, you see this, now we've flipped our thinking, the higher numbers are better. We have as high as 58% of the women in Region 13 to as low as 36% of the women in Region 5 receiving recommended postpartum care visits. And our map now is back to what we're used to. Darker colors do indicate better performance. And again, many areas for improvement if you want to look at how Texas compares nationally. You don't see any areas of the state where the regions are performing at the 75th percentile or better. And we've not seen a lot of change in this. I'm just showing the postpartum care from 2009 to 2013, but again, relatively static from 2009 to 13. So hopefully with all of these initiatives and with the different pay for quality programs and performance improvement projects, we'll see changes at the state level. Now that doesn't mean individual improvement has not occurred. It has. There has been individual improvement within some of the managed care plans. This is just looking at the state as a whole. So, again, there has been individual improvement in certain areas. If you look at a plan level, if you look maybe at particular facilities or physicians, but as a state, the line has stayed relatively static. So let's shift our thinking a little bit and move into the potentially preventable events, which is a focus of a lot of your work in one way or another, either through registries or through care transition projects. Some of you were talking about community health workers. In one way or another, you're trying to keep people in the community and out of the hospitals. And pediatric asthma is certainly a very significant issue. And so this is looking at asthma admissions per 100,000 members for a principal diagnosis of asthma in 2 through 17-year-olds. And so here you again can see a lot of variability throughout the state. You would prefer that there's very few admissions for asthma because it's believed that this could really better be treated in an outpatient setting and prevented. The statewide rate is 12 per 100,000, which is really relatively low, but there is variability ranging from 34 children per 100,000 down to roughly 6 per 100,000. And so here in this instance, lower numbers are better. And you can see there's some areas of the state that are doing really reasonably well in keeping children out of the hospital for asthma, and some other areas of the state where improvement definitely is needed and more intervention is needed. This is looking at the pediatric diabetes short-term complication rate, ages 6 through 17. It's also a rate per 100,000 member months. And forgive me, the earlier one was member months. I presented them as members. It was member months, and I apologize. So this is per 100,000 member months. And if you look at this, again, the statewide rate is pretty low. It's only about 3 per 100,000 member months. But there is a range from roughly 5 in Region 4 down to less than 1 in Region 17. So lower numbers are better. And this is really, again, overall really good performance in the state, but something to continue to be diligent about and focus on. Now, the other thing that we also do for the state, in addition to calculating the AHRQ prevention measures, quality measures, we also use the 3M software to calculate potentially preventable events, admissions, readmissions, emergency department visits, and complications. I'm only going to talk about 2 of them today, the admissions and the emergency department visits, because there's a lot of detail around these. But potentially preventable admissions, as the slide says, are admissions that may have resulted from lack of good access to care in an outpatient setting. It could be related to a variety of what they call ambulatory care-sensitive conditions, such as asthma, such as diabetes, and others. And this is based on a series of software tools that 3M developed. And one of the things I want to point out around this is that we do look at the severity of illness of these patients using the clinical risk groups, which is a software that groups patients according to severity of illness. And then what we do is we look at what the actual potentially preventable admission rate was based on what we would have expected based on the patient's illness severity. So there's an actual to expected ratio, because when people are admitted to the hospital, you really have to take into consideration their overall severity of illness. So this is presenting the ratios broken out by the regions and looking at the actual to expected ratios. And let me just take a minute to explain the ratios a little bit. So ratios that are under 1 indicate that there was a potentially preventable admission rate that was less than expected based on the patient's illness severity, and rates over 1 indicate that there was a higher potentially preventable admission rate than would be expected based on the patient's illness severity. And so in this instance, higher numbers are not good. Numbers that are centered around 1 means that the admissions were about what we would have expected based on the patient's severity of illness. So if you look at some of the darker colored regions, you can see that there are concerns in some of these darker colored regions of the state around potentially preventable admissions. So very important to look at those, as you have done. And if you look at, these are some of the top reasons for the potentially preventable admissions. Topping the list, and this has been consistent, we've consistently seen this in the years that we've worked with the 3M software and identified these patients, we very consistently see respiratory issues at the top of the list. So in this case, you're seeing pneumonia and asthma, but also cellulitis and skin infections. And the cellulitis and skin infections can be related to a lot of things. These can be people with diabetes and chronic conditions that have difficulty with skin infections and abscesses and cellulitis. It could be just living conditions, the heat. I mean, there's a range of factors that could contribute to that you would need to drill down into. The other thing I want to draw your attention to, you can see also on this top list, the top 10, bipolar disorders. And in some other analyses that we're doing, and you see this in your practice all the time, as you see this combination of physical and mental health conditions, co-occurring physical and mental health conditions, you start to see in those individuals higher and higher potentially preventable admissions, readmissions, and ED visits. So these are very high-risk populations. So again, pneumonia, respiratory conditions in general, skin disorders, diabetes, bipolar, huge issues when you start looking at potentially preventable admissions. Now, what I had presented were rates, actual to expected rates of admissions for these potentially preventable conditions. But now I'm shifting gears to actual expenditures. And you see a little bit different pattern, and I don't have the slides where I can put them side by side, but you can see a little bit different pattern of actual to expected expenditures on potentially preventable admissions versus the actual rates. They don't always align. So you could have rates that are as expected, but your expenditures may not be as expected. Now, you would have to drill down as to why that is. Is it due to the cost within the facility that you are working with? Is it due to people ordering a lot of things when the patient's in the hospital, a lot of services? I don't know the reasons for it, but the rates and the expenditures don't always align. So when you're looking at this is actual to expected, and we're looking at expenditures in millions of dollars. And so the first bar shows the actual expenditures, and then the second bar shows what we would have expected in expenditures after adjusting for the patient's severity of illness. So if you look at Region 3, just as an example, their actual expenditures exceeded what we would have expected based on severity of illness for potentially preventable admissions. If you look at, let's take Region 5, which is a little bit here in the middle, you can see that the actual expenditures were less than what we would have expected based on the severity of illness of the patients. So this can give you, again, very useful tools to try to think about, well, gee, my rates may be okay, my expenditures may be high, and why is that? These are ED visits, and a similar concept, emergency room visits for conditions that perhaps could have been treated in non-emergency settings. It may indicate lack of follow-up, poor access to care. There can be a variety of reasons. And much like I presented earlier on the potentially preventable admissions, we're using the 3M software, and we're grouping and using the clinical risk groups to adjust for severity of illness when we look at the potentially preventable ED visits. So here, again, this is the same thing. We're now looking at actual to expected, and there's a range ranging from Region 5 that has fewer ED visits than expected based on case mix to Region 13 that has somewhat higher ED visits depending on case mix. And so why is that? Well, here are some of the top conditions that we're seeing, and respiratory again. So upper respiratory infections, you really see people going to the emergency room as the #1 reason across the state. It may vary by your region, and we have those data. I'm just presenting the statewide information. GI, nausea, vomiting, abdominal pain. So these are things that you would, are not unexpected, but these are perhaps different kinds of conditions that you could drill down and see, well, what are the reasons for this, and how could we better treat people in outpatient settings. This is showing the actual to expected expenditures around the potentially preventable ED visits, and it's expressed again in millions of dollars. And you can see for region 3, 9, and 6, they have expenditures that are higher, which is the first bar, than what we would expect based on the severity of illness, which is the expected value, which is the second bar. So again, there's not always an exact match between the rates and the expenditures, and both are important pieces of information to look at as you work on your quality projects. So now for next steps, and this is where I'm hoping we can have some discussion. We really would like to get your feedback. We're trying to leverage, you all have data. Some of you talked about the challenges of extracting data from your electronic health records. Some of you talked about challenges of ICD 9 to 10. But we really would like to get feedback. Are these the right measures? Again, we only selected some to present today at lunch. Are these the right measures? How do we begin to capture more information that would better align with your projects? So one way to do that, and I'll throw these questions out and then we'll stop and have a discussion. One way to do that, certainly we're working with the state of Texas to get the all-payer data, but that doesn't really get at all of the measures that we might like to see. So one of the things that we're doing in Florida is we have a project that is funded through several different sources where we transmit very limited data sets from electronic health records to a data trust. And there is an honest broker system with intense security in place working with each site to look at quality of care. And we're doing that for two main areas. We're doing it for hypertension and obesity. So there may be options to set up a data trust and transfer some electronic health record data. I'm happy to talk to you more about how we do it in Florida and exactly what we do and what the security is around it. And those are some very exciting opportunities where you can really then become much more specific about actual patients seen in your projects, as well as get much more specific about data that's not commonly found in administrative data like claims data. So there's a lot claims data can tell us, but it has its limitations. So that could be very exciting. And then what measures, where does Texas have the greatest opportunity for improvement? Where could you really get, really improve the health outcomes and the health of the citizens of Texas and have the greatest effect on that, as well as really thinking about the ongoing quality within the facilities and practices in which you work. So this was just preliminary information. It's 2013. As I mentioned earlier, 2014 data will be available to the state, organized by the health, your health partnerships, your regional health partnerships in October. And the other part of it is why are some of these doing better and some not? Why are some of the RHPs doing relatively well? Some may be, hey, we look at that, we say, wow, some of the rural areas have real challenges. Some of the more urban areas are doing better, but it's a mixed bag. Some of the rural areas and more challenged areas seem to be doing well in some things relative to urban areas. So there's a lot that we could drill down and look at, but again, this is now your time to think about what next steps do you think are important. I know this is really important for HHSC, for us to hear from all of you. So let me stop there and take questions and discussion.
So in with regard to the Texas data versus national data, here I am.
Thank you. Okay.
Do you have any way to adjust for the different levels of eligibility, which are pretty low or difficult to manage in Texas versus other states? In other words, when I look at the data, I see some things that would suggest people are maybe have unmet needs and don't enroll until late. So that's sort of question number one. Number two, when I look at the differences between the regions, surely we have the way to break those down into individual managed care plans. In other words, when we look at a region that's doing poorly, is that because there is a managed care plan in that region that has most of the enrollees that is doing poorly, or are there other explanations?
So I think let me answer your last question, and then Deepa, I may call on you to help me with the first question a little bit. I want to introduce Deepa Ranka. Deepa's in charge of our data analytics team, which is really, Deepa's been with us on the Texas project for, I think, almost its entire time, and really has just done extraordinary work. So to answer your last question, first, yes. So as in our capacity as the External Quality Review Organization, we produce these results for each of the managed care plans by region. So if a managed care plan is operating in multiple regions, we report plan by region, which in that language would be the service area. So yes, that's what HHSC normally gets from us. We reorganize the data to present it by your RHPs. So certainly some of the explanation may be some variability in plan performance. As I mentioned, we do see that some plans continue to improve, others have been a little bit more static. I think some other explanations, though, certainly include, we do a lot to look at the context of care. So looking at the depth of poverty. Poverty is not all the same. There's deeper poverty than others. And so we do a lot in our analyses looking at how extreme is the poverty in a region or at a census tract level, what kind of health resources are available. So there's many factors like that, and it is possible to include those in our analyses and look at how much do health plan factors play into the results we're seeing? How much do neighborhood census tract factors, access to healthcare infrastructure? That's all possible and definitely could be done. In terms of NCQA, NCQA for certification purposes for plans does take into consideration some geographic variation, but they don't take that into consideration when looking at the results assessing quality. Basically, the thought is women should be getting their prenatal care. It may be more challenging in some areas than another, but this is the standard. And Deep, I don't know if you have anything to add. Is that generally? Sure. Oh, you need one of these? Oh.
So Deepa and I were just talking about, on the HEDIS measures where Dr. Shenkman talked about the difference between Texas and national. You're correct, Dr. Holcomb, that there's a lot of things we need to think about there. I think for children and pregnant women, where Texas Medicaid and other states have a similar coverage, maybe more comparability in low-income adults, where Texas isn't covering many low-income adults except if they're disabled or pregnant versus other states. We definitely would need to keep that in mind. Also, this data is through 2013. Texas recently carved many more behavioral health care services into managed care. So a lot of this data predates some of our further integration of behavioral health care into managed care. So I think there's a lot of things we would definitely want to look at as we were assessing this data about what our Medicaid managed care program covers.
Yeah, Lisa, thank you very much. And it will be interesting when the 2014 data are available to look at the trends. So we'll be able to do that in October. Dr. Lackman. Oh, I'm sorry. You have someone over there. I apologize.
Hold on. Baby, you get your time. Let me go ahead and do it. Thank you, Betsy, very much. And I want to expose my breathtaking naivete by asking this question. So I'm sorry I don't know the answer because I should answer it. But with the HEDIS measure of antidepressant medication maintenance, how do you account for people that the doctor is doing good care? And it's like, oh, you've got sexual side effects with Zoloft, I'll put you on Wellbutrin. And oh, you've got photophobia on Wellbutrin, let me try Remeron. But in other words, the doctor is assessing and changing the meds. It would strike me that that would look like high discontinuation rates when it's really medically supervised discontinuation rates.
Deepa, correct me if I'm wrong, but the measure takes that into consideration. These are people that we don't see any filled medications. So if you've got somebody on one drug, they're being switched to another drug, then they're getting a drug. Now, where I thought you were going with it is, well, clinicians can't be with the patients 24/7, and sometimes they're not filling their prescriptions. And then that gets back into the social determinants of health. What do we need to do at a community level? I don't think it all falls back on the clinician.
Betsy,
Oh, okay.
I'm over here.
Thanks.
Hi. Mary Dell Peterson. I'm just thinking that moving forward, it would be better if we could eventually get measures as recommended by IOM, the STEEP measures, where we're really, I know it's harder, but where we're looking more at outcomes than in processes. So if we take, for example, the 7 and 30-day follow-up measure, we spend a lot of time and energy in trying to improve that measure, but nobody has really shown it makes a difference. So it doesn't decrease your readmission rates or anything. And so, again, well, child visits, we all think they're wonderful, but, immunizations are actually some of the outcomes that we're looking at. Prenatal care, similarly, it's great, although there's some arguments in the literature about how many visits, somebody who's doing well should have versus a complicated pregnancy. And yet, I think we really should be looking at what are the outcomes of that pregnancy, the preterm birth weights, the low birth weights, those kinds of things. And I know those are really hard things for us to measure and come up with, but eventually I think we need to work on more outcomes and less process measures.
Yeah, and Dr. Peterson, I think that's an excellent point. So a couple of things. First off, if we look at the evidence base for many things that are done in healthcare, it's shaky. That's for sure. But nonetheless, there is professional consensus that children should have well child visits. There are some proven benefits to it, prenatal care and so on. Is it 100% ironclad? No. But the issue with outcomes, I do think, and I know clinicians can be very frustrated with electronic health records, and those of you trying to get data out of the electronic health records can be very frustrated. But I think with the advent of really extracting data from electronic health records, this opens the door to really looking at more outcomes that otherwise are too expensive and too difficult to collect. So again, I think there are abundant opportunities. We're very happy to share what we do in Florida. We're bringing data in on approximately 9 million Floridians into a data trust in partnership with some major health systems throughout the state. And a team of biomedical informaticians. Deepa's got part of a separate group that works on these things as well. And so I think there's a lot that can move us in that direction, and that may be an opportunity for a pilot to identify a couple high-impact projects and really define outcomes and bring the data into a data trust from electronic health records.
Hi.
In a big room, I apologize.
No worries. Can you hear me okay?
Yeah.
So I'm Nicole. I'm one of the anchors, a little bit of a different perspective. But this comment's really kind of to you as well as Lisa and our DOS, which is you've asked an important question that around what other measures would we like to see, and that's an overwhelming question. And so as we look at the development of Category 4 going into 2.0, I think we'd want to have this conversation again. So I just ask for that and a more focused one. But second, one of the things that you had out was around the trend data for it. And there's really not been a lot of variation over the course of time on the ones that you highlighted today. So it would be helpful as we think about giving them feedback on what measures we want to choose at our regional level, which ones have had some variability, so that would be helpful to us or for me. So we could look back and see why did something dip or spike, and identify where we might have had a success that we stopped doing for funding reasons or something like that, kind of, and it is more process question, but that might help us choose our measures as we go into Category 4.
Sure. Yeah.
So that's a request. And then my more substantive, no, not substantive, tactical question is the expenditure data that you had, is that controlled for anything?
So the expenditure data is using actual paid amounts in the Medicaid data. And it's not, it's not controlling from the standpoint of looking at resource units. And DEPA, I don't know if you want to describe a little bit about how that was calculated, I think, because DEPA does all these technical calculations, so that might be helpful if there's a microphone nearby and DEPA could. Yeah. It does control for severity of illness, by the way. But
yeah. So the actual to expected, the ratio that you saw on the first slide, is adjusted by resource utilization. So there's standard weights, which are used for all patients across the board, depending on the disease type. The expenditures, it is risk adjusted by the same factors, but those are actual paid amounts. So it's not adjusted for teaching hospitals being paid higher.
Hi, Betsy.
Hey, Dr. Shenkman, how are you?
One of the things which there's been discussion with on ongoing years about the HEDIS measures, sort of echoing Dr. Peterson's, is also whether the measure actually measures what it's supposed to and relates to outcomes. So for instance, in the asthma measures, the present measures really reflect outcomes in terms of ER visits and admissions much better than the measure that's being retired this year, which was basically worthless in terms of looking at outcomes. But one of the challenges, I think, on the postpartum measure is that the HEDIS measure is not aligned with ACOG criteria. So ACOG criteria ask for an earlier visit that's not within the HEDIS, time frame for high-risk pregnancies, which a high number of Medicaid pregnancies would fall into. And so I think in looking at this data, to me the question was there a postpartum visit in the HEDIS measure, or was there a postpartum visit, period? And then we also have some challenges with miscoding, where some visits may be being seen as family planning visits, for instance, and providers are not making use of the ability to bill both the postpartum visit and the family planning visit dually, one of the few places you can bill for 2 visits in one day.
Yeah, so with any of these measures, just so you know, one of the reasons why many states, it's not just Texas, focus on HEDIS, is that are they perfect? No, but are they measures that were developed through consensus, through strength of evidence, through a very clearly defined process? Getting measures accepted into HEDIS is actually difficult. Now, periodically they realize something didn't work, so they do retire measures or update measures periodically. But the National Committee for Quality Assurance has a very extensive process around this. So again, as we evolve and have more EHR data and easier ways to access those data, I think that we will start seeing more and more sophisticated measures. And certainly in the years that I've done this work, we have seen a lot more measures come out from HEDIS that I think are increasing in their utility. But your point's well taken, and you do have to monitor coding. That is extremely important to make sure that people are coding correctly, and sometimes there is not total agreement with professional societies.
Hi, Betsy. Thank you for the presentation and the analysis. I think it's really helpful, especially looking at regional bonus pools and how all that's going to play out. But 2 quick questions. I'm just going to do it, and you can cut me off. But one is, I thought it was fascinating, the actual to expected expenditures versus the straight up rate. And just wonder if you could throw out a couple thoughts about what might be driving that. It seemed like maybe that's related to the utilization pattern within the HMO or the particular patients, or else it could be on the payment rates, potentially. And I'm sure there are other factors, but that's one. And I'll stop and see if I can do a second one.
Okay. Yeah, so I actually, honestly, Maureen, think it's both. I think part of it is what has been negotiated with some of the facilities. And so those payment rates, I think, are part of the issue. And then the other part of the issue, there are certain ways of practicing where people will order more. And so we haven't taken, say, a use case. We haven't taken a use case to say, well, let's take one of these upper respiratory infections and let's look at, well, where are there variations in what the paid amounts are and where are there variations in the amount of things being ordered to deal with that respiratory infection. That can be done. And again, could be very useful to inform the RHPs.
I think that's a great point, because then you can drill down to see what's driving the variation.
Right.
The second point is just thinking about going forward. You're showing data that's HMO, Medicaid data, and one of the questions raised was, are we looking at what's being driven by the HMOs? And so if you look at some of these similar rates, I think, is it fair to say a caveat would be to say, ooh, what's really being driven by the HMO within a region, and what really is kind of able to be driven not by the HMO, but really by the other people accessing the DSRIP funds that are being held liable or responsible for something that's largely affected by the HMO? And how would you, what caveats would you want to consider when you look at some cross-regional bonus pool or intra-regional bonus pool?
I'll try to give a real abbreviated answer, because this can get into the whole area, which is very, some of the representatives of the managed care companies will tell you risk adjustment's a very touchy area for them. But that can get into then, when you look at the bonus pool, potentially risk adjusting for, again, the contextual variables, including poverty, resource infrastructure in the area, also controlling for the managed care plans. I mean, there's a variety of things that could be done statistically. But that can be fraught with problems because people don't always agree on what's the best method to do that. And then also it makes it very difficult during the year to track your performance, because the risk adjustment is done at the end. So people can think they're doing well, but then the risk adjustment's applied and all of a sudden they're not. So it's complicated to answer that, but that's one we'd love to talk more about it. We think it's a very important area related to pay for quality in these different risk pools. Okay, any other question?
Mike Romano from Texas Tech El Paso, Region 15. One thought on additional analysis: as you start to look at this data, it might be very helpful to look at the breadth of the provider pool that's actually providing services in some of these areas. And I just know my little corner of the world where it's wonderful to have collaborations and such, but the number of psychiatrists out there is just not sufficient. And so strategies, when you start to look at how you can tackle the problem, may be very different, from Central Texas compared to the periphery or the valley.
I agree with you completely, and that's the other way that some of these statistical analyses can be used, is not so much for a risk adjustment, but to say, well, okay, when we look at the variability in results across these RHPs, well, when we put in there, let's just say rates of primary care providers per 100,000, well, there's part of that's soaking up in statistical terms part of the variance in the outcomes. So I agree that, it's very important to take that into consideration.
Hi, thanks very much, very interesting. The measures, in answer to your question, certainly seem to make sense in terms of the right things for us to be looking at. In the state pay for performance program, we're allowed, we can request and are able to drill down to raw data to actually get underneath and learn with you what the patterns of practice really are, and what are some of the variants that explain, in this case, for instance, the potentially preventable admissions. So is there any plan at this point to similarly allow us to find out cases to drill into to get a little more detailed understanding for ourselves?
We do that sometimes with the health plans. That's a resource issue for us and something HHSC would have to address. So if that's fair, I'm going to kick that over to Ardas and Lisa, if that's fair.
And we would have to take a look at that. We would want to make, if we end up using some of these measures for DSRIP purposes, we would want to make whatever we could available. There may be costs associated with that, or resource constraints that we have. But, and the other thing I just want to mention, and we know this, we're looking at 2013 data, which is really before DSRIP got off the ground in earnest. So this would be Medicaid, with all the qualifiers, really baseline data for what we'd be looking at. So hopefully when we see the 2014 data, to Nicole's point as well, you know, I mean, that's still pretty early in district, but I think part of the goal of this is that we do want the health plans and the district providers, to the extent that you're serving Medicaid, to be rowing together, trying to work together, trying to align the incentives. The managed care plans have pay-for-performance elements of their contracts. District is going to have a pay-for-performance element. And so to the extent that we can, to align those so that you all have an incentive to work together, because a lot of times you're serving the same patients.
I know a gentleman's had his hand up over here for quite some time. Yeah, okay.
Thank you, Pat. This is a related question. I know there's some kind of provider ID information in the Medicaid claims, and I'm wondering what you think about the idea of trying to drill down on this area to try to identify patients or Medicaid enrollees that have been touched by or served by district providers versus non-district providers, and whether or not you've done any kind of comparative type project like that at the provider level.
We have not. Now, you know, so Deepa's smiling at me because Deepa looks at me like that when she knows it's a very complicated analysis. So again, that is very much along the lines of what Lisa was talking about earlier. It would be a resource issue. Could we do it? Yes. It would be a resource issue. And also some of the provider files have flaws in them. So we'd have to, you know, it would really have to be something where A, there'd have to be resources to do it. B, there would have to be the ability to do some test cases and make sure the quality of the provider data was sufficient for us to do it accurately.
And I would just add, and I don't even know if I can get a mic, that, you know, people have asked us, we do not have the Medicaid IDs of the people being served by district right now. And one of the things that we have proposed for the extension period is that HHSC would like to collect the Medicaid IDs. That would allow us to do the kind of analysis to cross-check against our Medicaid data to see which projects are really proving up to have great results. But without those Medicaid IDs, even at the provider level, we can't tell who's directly being served by district projects. So I know we've had some pushback on giving us Medicaid IDs because that's an additional administrative burden. We think it would be a great value to demonstrating the success of district.
Yeah, I agree. That would be really, really important, and thank you for bringing that up, because, right, you have to have the patients and the providers linked together, and if you can't do that, it won't work.
I just have an overall comment. I'm Rose Calhoun with Texas Children's Health Plan, and there's always a lot of discussion about what measures do we use and what's the most current. It is a tedious process to get a measure accepted by everyone, but the value in having a national measure is we can benchmark against people in other states. The other thing, when we talk about getting the data and how is the health plan doing, and how is the hospital that has a district that's working with us doing, we're all partners in this together. Texas is the 10th state I've worked Medicaid managed care in. This is my home state. But when I started working on this project, I took the Excel spreadsheets that I received from ITIP on the PPEs. I met with a person over at the hospital who had their Excel spreadsheets of PPEs, and we both did our analysis the same way. And we have a really nice PowerPoint where we have his data, my data, his data, my data. And basically, we are on the same ship. And we have the same issues. We were able also to drill down and look at specific cases and identify some outliers that were causing some of the blips. But, you know, we're in this together. We all get data from them. But when you put it together, if a hospital has the majority of your members, you match. Your charts match. And so you can come to agreement on, we've come to agreement on what we're going to work on together.
Yeah, that's great. Thank you, Rose.
I think my original question has changed by this point, but and I hope I can articulate this well. So the data that you presented today was very nicely presented, but I'm struck that the basis for the way it was presented assumes that we're looking at samples or populations that are somewhat arbitrarily defined by the way the regions were set up. Mm-hmm. Not that was entirely arbitrary. So I guess my question is are we looking at the data with the right fidelity? I mean, should we be looking at this by census tract rather than by region? Because I can't quite tell what's happening in a given county or census tract and how that might be influencing all of the providers or the issues in a given region around that, and how that might actually change the way the data looks.
Yeah, so that's a fantastic question. So how you cluster people together matters, particularly for statistical analyses. It's extremely important. We have done some analyses looking at the STAR Plus program where we did clustering at the county level. That paper, by the way, was just published in Medical Care that shows some very positive outcomes associated with the STAR Plus program. And our clustering was at the county level and how we did our analyses. So that's very important. Now, the downside to that kind of clustering, however, is that then you start running into very small numbers, and then you can end up with a great deal of instability. So you really, we had to narrow, for example, in that analysis of the STAR Plus program, we had to narrow it down to a few measures that we knew would work well at a county level where STAR Plus was operating. So there's always trade-offs, but you're right, it is a very important decision. All right, well, thank you very much. This has been a real pleasure, and I really appreciate being here with all of you.
Hi, everyone. We've got a video coming up from Region 6 in just a minute. But before we do that, I want to walk us through the rest of the afternoon. Once we wrap up here, we've got 4 breakout sessions, one on conducting program evaluations. And I know lots of you are pursuing those with Stretch Activity 3. Second one, strategies for collecting and using data more effectively. Session C will be about the HIE and the ADT feed. And session D will be talking about aligning care with managed care. After that, we'll have a poster session. For those of you who have not visited our posters, they're in room 304 to this side of the ballroom. Excellent projects over there, so please stop by and visit. There'll also be networking here in the ballroom. When that concludes, we will all rejoin together to discuss our next steps with the waiver. Thank you. Let's start this video.
2015 marks the 4th year of the Texas Healthcare Transformation and Quality Improvement Program. This Medicaid 1115 waiver has ignited incredible efforts to improve health and transform care across the state. Regional Healthcare Partnership 6 includes 25 providers across 20 South Texas counties and is anchored by University Health System. These community mental health centers, physician groups, public health professionals, and health systems are partnering with stakeholders to implement 124 delivery system reform incentive payment projects. These DSRIP projects are focused on addressing 6 critical community needs. First, RHP 6 is working to improve access to care.
We really are taking care to where children and families and adults live, work, learn, play, and pray. We've grown from 1 clinic and 1,700 patients when we began to 6 clinics and 14,000 patients. So this is a nurse-led model, and we can do this for 30% of the cost of traditional medical models.
We were able to expand services by hiring and recruiting more providers. We also were able to get mobiles to be able to go to school districts and neighborhoods. What has been our biggest achievement is the better collaboration, understanding, and communication that we have developed, not just within our own organization, to work together for one and one reason is to improve the health of our community.
RHP6 is improving the prevention and management of chronic diseases.
The YMCA of Greater San Antonio is committed to serving all individuals in our community, and partnering with the 1115 waiver has allowed us to offer our diabetes prevention program free of charge to anyone who lives in Bexar County. San Antonio being described as the city of the future, the rest of the world is looking to us and how are we going to stem the tide of type 2 diabetes and the crippling effects financially and personally this disease has on our community. So we have a huge responsibility to get this right.
Well, one of our projects is a chronic disease clinic. And through that clinic, we have been able to provide primary care to a group of uninsured individuals who, before the project had no access to health care outside of an emergency room. Now we're able to follow this group of people, look at outcomes, and make sure we're actually improving their health.
We hired a dozen new community health workers. What it did was it offered us this thing we never had before, which is a window into people's actual lives at home. So for instance, a patient has diabetes, they come to us over and over, and we talk to them over and over about their diet and their medications. Then we go to their home and we find out, when we ask the person and look in their pantry about their diet, that they're actually living on $3 a day for a food budget. And so a lot of the things, the advice that we've been giving them, isn't relevant to someone who's got that low level of money to pay for food. So it's made us much more realistic in terms of the advice and the teaching that we give to patients, and it's allowed us to engage help for them in new ways.
RHP6 is improving healthcare quality, safety, and the patient experience.
We've seen that by investing in our staff and giving them the training and the tools to improve outcomes on a daily basis, that we have been able to accelerate the rate at which we make changes and improve clinical outcomes, patient experience, or operations. We have learned quite a bit from other facilities that participate in DISRIP via the learning collaboratives on readmissions. We shared what we were all doing, and everybody's in the same boat, and it's nice to just be able to talk about what are you trying and what worked and what didn't, so that we can learn from each other.
RHP6 is improving and integrating behavioral health care.
Hill Country's been able to work with 4 regions throughout the state. It's brought us together with other healthcare providers such as hospitals and physicians' offices to bring psychiatric consultation to their service sites to help people where they initially approach people for psychiatric needs. And then in addition to work with jails and judges and county commissioners to develop full services of care to meet the needs that they have within their communities.
RHP6 is improving maternal and child health.
Our project is improving the health of our community by reducing teen pregnancies. And so by reducing teen pregnancies, we're really reducing child poverty, we're reducing low birth weight babies in our community, but we're also helping young people finish school, be prepared for a future where they can really enjoy and be part of our economic opportunities here in San Antonio.
RHP6 is reducing infectious diseases like tuberculosis.
We're able to detect people with the latent infection and then treat them so that they do not later come down with tuberculosis disease, which is not only a risk to their own health, but is also a risk to the community. We're reaching out to local providers, hospitals, clinics, homeless facilities, federally qualified health centers. So we're getting to know the providers in the community in our area. So it's very beneficial. I'm making connections and relationships with this project that will extend beyond this project and will help to improve public health in this area for years to come.
These are just 9 examples of the 124 DISRIP projects underway in RHP6 to improve health and transform care. To learn more about how you can partner with RHP6, please visit www.texasrhp6.com.